Hello, everyone. My name is Ken and Rooney. I'll be facilitating today's webinar about claims and utilization management risks. Just a couple of housekeeping items before we get started. Um, Today's program is being recorded, and if you do have questions, please feel free to submit them in the chat. I can help facilitate those questions as Todd and Ken will be. We have a presentation that they'll be going through, but we'll try to consolidate the questions, and there'll be time at the end for Q&A if you all would like to do that. There is one CPE credit available for this session. So in order to receive that CPE, you need to participate for the duration of this webinar, as well as there's 3 polling questions that you'll need to be answering during this webinar. After the webinar, it'll take us 2 weeks to get, you'll be emailed their CPE certificates within 2 weeks, as well as there'll be a survey. So with that said, I'd like to pass it over. These are our 2 speakers today, Todd Gower, who's the VP of Healthcare at RGP, as well as Ken Stockman, the CEO of Beacon Healthcare Systems. I'm gonna let them introduce themselves and start with the program. Todd?
Great. Nice to meet everybody. So we look forward to the conversation and interactive conversations too. So we'll make sure questions and answers are there for everybody. But my background is stated years. I've been in healthcare about 22 years. Have been working in industry as well as consulting, along with supporting CMS on the RAC MSP program and other special projects, along with state Medicaid program integrity. Love to have the conversation what we have about claims utilization and payment integrity. And next, I have my guest, Ken Stockman, who he and I both work together. We were doing some work at CMS.
Thank you, Todd. My name is Ken Stockman. I'm the CEO and founder at Beacon Healthcare Systems. My background is I first started in the payer space in 2004, where I started a company in Medicare Advantage before there was any Medicare members enrolled, actually, and built that company up. It was primarily risk adjustment and enrollment and a few other core products in that company. And then, as Todd mentioned, I spent 3 years at iHealth Technologies in the payment integrity space, working on the RAC as well as with a lot of our clients as a market leader, and then now CEO, as I said, and founder of Beacon Healthcare Systems. So we work 100% with payers. We have a great set of clients. We're excited about it, and we'll talk more about it as we get through the slides. Thank you, Todd.
Thank you. Ken? So we think about our key learnings today for those CPEs. There's learning involved, but our main goal here is to get you informed about what we see as major concerns and do's and don'ts, and also some top 5 issues and concerns you could think about when you want to look at a solution to help you with the problem. But we'll give you an overview of claims utilization and the process, along with communication is key, and then risk mitigation strategies, and also continuous validation. Those will be some of the key learnings from the discussion. So this is interactive slides. So Ken, if you could go ahead and continue to click through this. What this process does is let you look at how the claims get processed. So go ahead and click on Ken and each one. So the idea is that you're an individual getting care, and you want to talk to the healthcare provider. Data gets flowed in and out from that conversation with the doctor, either on site or tele or virtual of some sort. But when the claim is produced, there is this communication back and forth that happens between doctor, payer, and patient. That whole activity, it may seem simple on paper how it gets processed, but there are a number of key issues and concerns that go along this process that we in the space, when we look at this, data fields get missed, inputs are wrong, provider issues that happen on the coding and billing side, which then the payer rejects, or there's appeal or grievance activity. But this seems to be maybe simple on paper and process and thought, but there's a lot of complications around this in the technology space. And I know Ken has been doing this for a lot longer than I have, and I know Ken, just any other comments on this regarding the process?
No, I mean, this is perfect. I think, we'll talk a little bit later about where benefit design also plays a role. It's amazing, with some of my larger clients that they still have benefit design problems that then create rejected claims. So that's a very sticky part of the process that's sort of on the front end of this.
Very good. Thank you, Ken. Next page, we'll go a little more into Oh, thank you. What is payment integrity? So again, this is interactive as well. When we think about what we mentioned earlier about the process, there are all these gateways and all this data that's being transferred back and forth. And when we think about the reviews for anomaly detection or potential errors that take place, this process, when we look at payment integrity, is key for health plans. And making sure that there's proper audit and review in the process so that, one, there isn't an overpayment or underpayment possibly, and that at the end of the day, the member or patient is properly being cared for. Again, reducing friction between member patient with the healthcare provider as well as the payer. So when we think about payment integrity is defined, it is just that, making sure a claim is paid correctly. And also the payments are treated at an individual basis, and that they're reviewed properly. And so we have seen this in our studies, and I know Kimmy has some other numbers too, but even when we were in the RAC space or even MSP and other programs helping out Medicare and Medicaid, the amount of improper payments, not that it's fraudulent, but the errors that take place. And that means clawbacks, that means potential balance payment back to member. But there's a number of improper activities that take place that render this inefficient. All right. Next page. Utilization management. So when we think about utilization management, payment integrity, they go hand in hand. But we think about the definition of utilization management around medical necessity, and making sure that's being done, that there's proper validation of patient activity, and that there are organizations that take a look at that from URAC and IOM that help in the management and oversight of policy and rules around this. And this has helped guides us, especially for folks like Ken and myself who leverage the technology to help our payers and providers, but specifically around this space, looking at how that's being done and that we can help detect those anomalies and also reduce risk for the payers. And I don't know if you have anything you want to add on this too, Ken in the space of UM.
No, do you touch on NCCI later, Todd?
We can if you like. Yep.
Or do you want to do it here?
Oh, do it. Good to hear. It's fine.
So I just wanted to kind of bring up when you look at payment integrity and you look at what the folks out there in the space are doing, there's really two buckets. There's NCCI, which is the National Correct Coding Initiative. And then there are edits that are clinical based. So when you think about how you're doing payment integrity and how you're reviewing the claims, as Todd just pointed out, kind of the low barrier is making sure the claims are coded appropriately per the NCCI guidelines. The other is taking a look at the medical necessity. So, is a particular procedure being performed on someone that historically doesn't get that procedure, and if so, that might get flagged. And so that all then feeds into the review process that we'll talk about later.
Great, thank you, Ken. The next page. So this is our first polling question.
First polling question, everybody. I'm going to launch this poll. How many of today's attendees, how many have you dealt with payment integrity issues? A, this is all new to me. B, I run a payment integrity oversight team. C, I was recently audited with the issue. Or D, I am part of a solution company focused in this space. A couple more minutes here. A couple more of you respond, please. Great. Primarily a solutions company focusing on this space, and a couple of folks here it's new or just recently audited. Great, thank you.
And thank you for that too. It helps us kind of guide some of the conversation, and then hopefully some good questions later on, especially those that are new to you. So I think from that standpoint, we'll try to keep this not too high level or get rid of some of the acronyms, but making sure that we've covered the basis of give you some more insights in this. So as Ken was mentioning on payment integrity, we'll do a little deeper dive in the space. Go to the next page. Well, payment integrity friction review. So we know that the audit activity that happens from payer to provider can be a huge friction. We're dealing with a number of our clients, and Ken sees this too as he helps out those clients, the providers. But it's amazing, a lot of providers do not understand the cost of this within their organization, and that it can administratively be a burden if they don't do it right. So as Kim was mentioning earlier, having proper coding and proper documentation can reduce this friction significantly. So when we work with your payer providers in the space regarding payment integrity, you can see that a lot of folks don't understand that it can be very costly just on side of potential overpayments that are being recouped, or that the issue of actually running the program to support it, it can be very costly. So what this figure has done, and Change Healthcare has commissioned this study around this, and Ken's organization has seen this as well. The costs are pretty are large, significantly large, and that would, if $500,000 can actually help put together FTEs and take away a lot of it takes away from a lot of investments needed on both sides of the fence. And what we find on the payment integrity piece is really trying to improve the monitoring of this. And we know that by improving the monitoring, which we'll get into a little later on the solution of some solutions around this, is making sure there's proper notification and proper anomaly detection. And then we know there's a number of technology solutions to help this, but really understanding the process, as we just mentioned earlier in that process flow side, is as organizations take a look at how they process claims and how they deal with the member or with the patient or with provider network or with providers in contracting, all that's key in dividing out the proper data activities so you can actually capture those properly and look at those. So I'm going to pause there, but I know that this is an area where there has been a lot of friction in the space, but they need folks like us as RGP and Ken's company go in to help support them in this. This is where we can help reduce some of that friction. I don't know, Ken, if you want to mention anything on this as well.
I don't think so, Todd. I'm good. Thank you.
You got it. Thank you. Yeah, I mean, I think that reducing these cost areas are pretty key, but this is where we can help support that process. All right. Next page. Payment integrity trends. So we know that as folks spend close to $4 trillion in healthcare, 10% of that, it could be fraudulent though. So that's a large number if you think about it. It's amazing what gets found and what we've had to recoup too in our days back working for the RAC, also working with SIU and other special investigation units or investigatory activities. We know that there is an opportunity there to deter this as much as possible. So thinking about it, as you try to put in solutions in place to help focus on this, you can help reduce that percentage significantly. And we know that the payers, specifically in the space, really struggle with trying to get their arms around this. And we know that a lot of them have really tried to use solutions, tech solutions, but it gets back into really understanding the business and the nuances around this and proper monitoring and detecting for this. So I know that it's a large number, but it can be reduced. We're working closely with some of our large payers in the space to focus on that trend so you don't have waste that's already compounded in healthcare. I'll pause there, and if Ken, you have anything else you add? And we're seeing trends in the payment integrity space from your point of view.
Yeah, I mean, I was just going to add that when you're thinking about, either your existing payment integrity process or needing to build a stronger process, a lot of my clients and others that I've worked with in the past struggle with what dollar size do we actually investigate. So you can have a piece of technology, as Todd just said, that's identifying potential inappropriate payments, but it could be, $10 or $100,000. So based on kind of your team size and your strategy, you kind of want to stratify your focus so that you don't get overloaded with, chasing peanuts, right? And versus getting the real bang for the buck, because as Todd just pointed out, you can't automate the whole thing, right? So you're only going to be able to automate through the technology, the identification of potential issues. Then someone has to physically go review it. So that can be a pretty big burden on a team.
Yeah, and again, it gets back into data overload, and you also have the if you try to capture too much, all it takes in the model of review, one or two fixes in IT and upgrades that can throw the whole model out of whack when you look at these anomaly detections. So like as Ken mentioned, really stratifying as best you can, and that's where folks like us can go in and help us support that review. Well, there are different ways.
Can I ask a question real quick, Todd?
Yeah, of course. Go ahead.
So Ken, actually, I don't know if Todd or Ken can answer this. I'm looking at bullet point 1 that talks about smarter tech, and the second sentence talks about siloed departments, legacy systems not being updated, isolated data sets. I'm curious how much of the issues uncovering these are really operational issues. Is it just an operational issues that's just kind of pushing these issues through, or is it really a systems issue? People, process, or systems kind of question here. I'm just curious. And then the second part of that question is smarter technologies. Are these tailored technologies? Are more than are most payers creating more homegrown systems than themselves, or are there better systems, just looking bigger picture, that can detect this? What you're referring to as smarter tech to catch these issues. So two-part question there: process or data issues?
But it's a mix of both. And wouldn't you say, Ken? I think it's some folks have the legacy systems they've held on to as a result of what system put in place. But then it gets back to operational teams. And I know, Ken, you mentioned this earlier, that they try to capture too much, not focused, and they're missing it just by doing too much. I don't know if anything else you want to add on that.
Yeah, I mean, from my experience, both back when we worked together, Todd, and currently, when you're looking at payment integrity, you've got two big buckets that create the most dollar impact, and there's two different. There's three. Okay, so what you're talking about, Todd, is the system configuration, creating problems, change in configuration, and Ken, in terms of the team challenges and all that. There's that bucket. But there's this other bucket that is significantly big. In most provider organizations, you have a different set of people doing the coding than provided the care. So if those folks are making mistakes in the coding, that can create a significant error rate or dollar impact. And then over here, which you don't want to really, hope you're not going to get a lot of, is the fraud, right? So you have this last piece, which is providers are intentionally miscoding in order to slip something through, right? So I've got X zillion of encounters and claims that I've done in a year. Every now and then I'm going to see if I can get lucky and slip one through. And that's where the technology can identify it. But the operational teams have to then go and focus on, was it truly, fraud? And if it was truly fraud, was it intentional or unintentional, right? So if it's simply a mistake, then the plan clients that we've worked with in the past are going to go and try and do more education with the coding staff and with the providers, as well as declining the claim. But then the worst case is you find that someone is actually being fraudulent, and that has to go kind of through SIU and through that whole process.
Yeah, I think that's a really good question, though, Ken, and said you think about this. There's three lines of defense, right? We think about compliance and regulatory monitoring. First line is that operational piece. Second is the compliance organization. Third is external, and third, internal audit type activities. And if they're all working together, they can help detect these things. But you're right. All it takes is that one individual or set of individuals that want to commit fraud. It could have been a mistake. And we found that some of our healthcare systems could be triggering scheduling events that didn't automatically get billed because that was a fraud process they want to flip on to be easy for them. But they realized, oh crap, that's not the right thing to do. And so, as Ken mentioned, it can be unintentional. But there's also recoupment from that too. So if Medicare paid for this or Medicaid paid for this, then obviously there's a responsibility for them to make sure that's done properly.
And one of the things that Todd, as you know, that's really an interesting sort of nugget is when you look at that fraud piece and you look at the country, you can actually narrow down where a majority of it is occurring by states. It's very interesting that there's very specific areas that the plans that are national plans are focusing on because that rate of fraud is higher than in another state. Yeah,
the OIG publishes, I guess there's about 6 or 7 different counties or areas United States where it seems to be prevalent. Not that the individuals living there are bad, it's just that it seems to be those counties where things are going a little differently. So, and yeah, if there's a rule around it somehow. So people are going to try to find it. But that's those, and that's a smaller percentage though, more and more. Even that number of 10% is big, but some of it's unintentional and some of it's intentional. And that what the good thing is that our healthcare system is pretty doggone good. And it's all relative, I guess, for those who are in really robust health plans. But with COVID, it has pushed the limits of how providers are engaging with health plans too. So there's an access issue. So and then you have utilization issues for providers not getting enough patients to pay for their services too. So there's this whole balance, as Ken mentioned earlier, like, oh, they might be adding a little bit more than they should have in the coding because they don't have the utilization they used to have. So there's a myriad of things that have happened recently with the pandemic that has exacerbated the systems and processes. Ken, does that answer your question a little bit?
Yes, thank you.
You're welcome. Great. Next page. So another polling question. Oh, you're on mute.
So payment integrity audits can be costly. What is the percentage of provider groups that have not been able to track their admin costs to manage these audits? So can I get a couple more people to answer the question? Got a mix across the board here, Todd. You might want to clarify the answer to this question.
What else? If you go back to the prior page, let me show you, let me break it down, right? So, and then now the person just give the answer. Go ahead and close this. I'll show you when we talk about that. The other prior page. So maybe I wasn't that clear. I'm sorry, before that, regarding the breakdown admin costs. So there's about 36 that do not have an idea, right? So we try to narrow that down. So there's 46% that understand it, it's costing them, but 36% of them do not truly understand what it's costing. They're just trying to get it done. They haven't caught up with those costs yet, and they're just trying to be responsive. I know back when Ken and I were doing this for the Fed, sometimes providers would send an entire FedEx truck of records. So when we're doing audits, and it was pretty amazing what the cost of that was alone on top of our costs just to do it too. So it's amazing once they start calculating that, then they become aware, like, oh man, what we could do better by reducing our poor practices and instituting some process improvement, we could reduce our overall costs and the bottom line. So that's actually that was a good point question, folks. And we didn't go into deep on each of the percentages, but those things that can happen. So when you think about what it takes just to have an auditor on board, what it takes the technology to monitor it, what it takes to review it, and then there are better ways and cheaper ways to do it if you have some of your systems in place and contracts in place and good monitoring in place. You can leverage solution providers to help support that, reduce those costs. Thanks, Ken. GRC. So before we get into this space, the nice thing about this, both Ken and I built them, both either in private industry or also in the government space. And so what we're seeing more and more of the term government risk compliance being more from the days of doing SOX, of capturing your program audits, putting plans in the system, to just capturing mitigation activities or mediation activities. A targeted system to support specific matters is key. So there's not one size fits all, but there's some tools that are very important and helpful. And what Ken's been building on this is great. We can talk a little more about this in detail as he goes into this space. I'll turn it over to you, Ken, as you talk about this. So.
Great, thank you, Todd. So as we talked about, and I was thinking about our conversation up to this point, and it's very interesting because if you think about the pre and post, claims review process, that's sort of front end of the compliance and accuracy process. So a GRC is really what enables a back end review and identification of key problems. So if you have for instance, like our solution, you can automatically run claims through our solution, and we've built audit rules that look for particular things that could be a problem. And so having a good, system where you can analyze, grievances and payment appeals, that's also on the appeals and grievances side. So there's really two pieces. There's the compliance GRC, and then there's the appeals and grievances. And just to clarify, if a provider submits a payment appeal, it goes through an appeals process. In Medicare, it's very defined. In commercial, it's really more defined by the state. But that's where you're going to find what we talked about before, which is benefit setup problems, configuration problems, different things that are creating a denial of the payment that's inappropriate. And so the appeals process can really identify those areas where we have systemic challenges and need to go and deal with that. And then when we talk about, again, in the appeals and grievances space, CMS has these audit universes where they're going to be looking for issues within the health plan that could trigger what Todd talked about, which is a program audit. And building these universes have a lot of time requirements around them in terms of turnaround times and accuracy. So it's really critically important that if you're a health plan, that you're able to provide these complete and accurate timely universes within the audit protocols. Claims universes are generally one of the largest provided during a CMS program audit. And then if you look at kind of those universes themselves, we have a compliance tool, an accuracy tool called our Universe Scrubber, which allows the plans to run their universes through our scrubber to ensure that they're compliant before they get submitted. Because if you submit inappropriate universes to CMS, you're going to get, an ICAR, you're going to get a finding. And so what you really want to be able to do is, the other thing too that a lot of our plans focus on is trying to make sure that that data that's being passed to CMS is accurate, because if it's not, it could be an audit flag. So there's two pieces to this, right? There's trying to make sure we get paid accurately. There's trying to make sure the members and providers are taken care of. And then there's making sure that we're meeting the guidelines that are regulated by CMS. Todd, does that make sense?
It does. I think what we find is that a lot of companies really struggle with consolidating all this information for those universes and creating mock audits. And because it is so comprehensive, especially large multi-state programs and plans, that capturing all that information timely, especially on completeness, accuracy, and timeliness, are really, really important for CMS. And a lot of health plans really struggle, to Ken's point, getting back to the root cause, to like which area had the problem. ODAG, you heard these terms, ODAG, CDAG, and the protocols. And it's amazing what the protocols are laid out by CMS of what you need to do. They just tell you what you should have, how you get there. Sometimes there's some gray what you need to do, but you got to be able to make sure you hit the requirement by CMS and the protocols.
And the reason this is so important from a CMS perspective, and I know we're not necessarily just focused on government programs, but
right.
What their charter is to make sure that the members and providers are being taken care of by the plan within the context of the regulatory agreement. So they use universes to look for plans that are potentially creating member satisfaction, delivery issues, or provider issues. And that's, again, I have a very large client that every day this month is waiting for a program audit letter. And it's nerve-wracking for them. Every day they expect to get the letter. So I bet them a steak dinner, they're not going to get one, but hopefully I'll win my steak dinner. But it is truly very important to get this right, as Todd was summarizing.
Yeah, I mean, because what will happen too, as Ken mentioned earlier, is that when they come in for a program audit, they'll ask these universes, and then showing that you've done your due diligence on a periodic basis does help them. You may already self-disclose that we've got errors in the space. It also helps the auditors too. So the more that you can do up front, showing your due diligence around this, better for you, and also allows you to correct those back-end problems on the operational side. To Ken's earlier question earlier, is this an operational issue, technical? It's a mix of all three, and depends on on the complexity of your plan and what you provide. Next page, Ken.
Just time check. We're at the bottom of the hour. Thank you.
Very good. Thank you.
Really, when we talk about sort of our compliance solution, which is kind of what I jumped in too quickly in the last slide, our compliance GRC solution is really where auditing and monitoring take place. And as I started to mention, we have built rules where we can run the data through our rules engine and identify errors. And a couple of key examples here is claims timeliness. So ensuring claims are processed timely in accordance with the guidelines. That could be an audit risk if they're not being processed within the guidelines. Sponsoring organizations must pay 95% of clean claims from non-contracting providers within 30 calendar days of receipt. And then, must pay or deny all contracted claims that do not meet the definition of clean claims within 60 calendar days of receipt. So these timeframes, you have to have a workflow process and a team that can make sure that these are identified and mitigated. And then, as Todd said, if you find issues and you're going into an audit, you're always better with CMS saying, I'm disclosing this issue, we've solved it, right? That we've dealt with it. When it comes to appeals and grievances, the past slide, we have many clients that have used us as their corrective action plan with CMS. And so, they when they get into trouble, they call us, which is great because CMS thinks we do a great job. And then claims interest payment, we need to make sure that the payment interest is done at the right time, is calculated the right way. We have rules within our engine that can identify whether the claims payment was accurate and timely or not. So these are just some key areas that our tool can help identify when it comes to claims.
Thank you, Ken. So I think next piece when you think about GRCs, next page, please. Oh, click it again. That's interesting. There we go. I don't know why those interacted. Sorry for that, Ken. We think about the requirements, right? So as Ken was mentioning, what you should have in consideration for a GRC system is making sure you have the right people, right programs in place. I don't want to steal your thunder, Ken. This is important, but you're thinking about some takeaways from this conversation we have around thinking about claims and payment integrity. It's really key to think about how you want to do this and monitor a little better. So go ahead.
Yeah, no, I think when you talk about a comprehensive GRC solution, such as what we have here at Beacon, you do have sort of the need to be able to manage kind of the regulatory guidance that's coming out. So you have the HPMS memos in the Medicare space. Each state has different regulatory guidance that they release, and it's really important that your teams or your clients are tracking these. So like we have a full chief compliance officer who spent 10 years at Molina. We have a whole team that goes through and identifies these things that are going to potentially impact our plans and how they're doing their desktop procedures or how they're managing their business. And then, as I mentioned a minute ago, the automated monitoring is critically important. And most plans are still doing very small set sampling, which is sort of the CMS guideline. We believe that it's a great opportunity to review more data and make bigger changes to your upfront processes to ensure you don't have downstream problems. And then being able to build your corrective action plans and have your dashboard reporting and your analytics to help you identify the key trends, KPIs. This is a great view into where the plan is potentially needing to improve, right? So if we're using this appropriately, along with A and G, appeals and grievances, they're two great insights to the health of the health plan. And a lot of plans don't look at it that way. They look at, compliance as something they have to do for CMS, and appeals and grievances just complaints. But the data that it's being produced is so valuable to help really identify, the key thing we're all aware of: people, process, or system change.
You can, yeah. So, as mentioned, try keeping it simple as possible for you to think about. Make sure the right professionals, and if you're engaging with a GRC solution, looking at that company, make sure they have the right people to help support this, because a lot of times GRCs will have a really good technology solution, but the people behind it sometimes are not fully aware or understand the processes, so they'll engage with other firms to do it. So you just kind of have a good understanding of who you're engaging with when you think about GRCs. Next page. So these are just some areas and examples I know that we talked about a little bit when we think about areas of improvement, root causes. And I know Ken did a great job of articulating some examples here, but we want to leave with you just some ideas. You think about thinking through duplicate payment issues, payment processing issues, prepayment issues, and this is where having a good tool in place is really key for that. You can't do it. You can try to do it alone, or with a couple individuals that can code, but having a repeatable, scalable system is going to be critical for your organization. If you want to touch on this a little bit, Ken.
No, I think you did a great job. I think the bottom here is just about member satisfaction. So,
yep.
You know, all appeals and grievances and CTMs are the complaint tracking module from CMS. So when a Medicare member calls 1-800 Medicare to file a complaint, it's tracked in this CTM, and CTMs are a leading indicator for audit risk for plans. So if CMS is out there trying to figure out who they're going to audit, if they have an outlier with the percent of CTMs or the volume of CTMs, they're going to go straight in for the throat.
Oh, yeah.
They're not going to take it lightly, because it's all about member satisfaction. And you know, Medicare Advantage is steeped in making sure those members are taken care of. Prior programs drove problems in member satisfaction or member care, and so there's a very significant kind of mission statement to make sure. So prepayment issues could lead to member not be receiving the services timely. Payment issues could lead to the member getting billed. You know, all of this adds up to member frustration and lack of confidence, and not only audit risk, but member retention or lack thereof.
Yeah, thank you, Ken. It's critical. Like, so hence why the importance of having your arms around all these issues and concerns, a system around that is critical for you if you're in a health plan looking at this space. Thank you, Ken. Next page. Again, we talked a little more about this too: prevention, detection, and overall improving satisfaction. So that's really all key. It's all key on this, right? So we're making sure that whatever you're finding and doing, whatever you're finding and detecting is properly monitored downstream, making sure everything is properly categorized. All right, next page. And I know we talked this a little earlier getting into it, but thinking about payment appeals issues due to claim issues. I don't know if you want to touch any more about this, but
I think we've touched on it already, but it's just you know, the payment appeals, when they go through our system or any system within the plan, they have very tight turnaround times to be processed. And so again, you have to have the right compliance team and the right compliance focus, and you have to have the right tools. In most cases, homegrown appeals and grievances solutions will not meet a CMS requirement. It won't stand up under volume, and it won't stand up under pressure testing. So that's why Beacon has a solution, and that's why we exist.
Yeah, I think the big thing in having reviewed the extracts manually for this, for some small 1 or 2 zip code health plans that are being started up, trying to do it manually is extremely difficult. And when they try to do this, yes, they will probably fail the first, second, third time, and then they'll get their ICAR, depending on the severity of what's been found. So it gets back into, yes, the protocols are laid out in a data format you can try to fill out manually, but to have this repeatable and scalable for when CMS comes in to do their scan, it's important to have a really good process and system in place for this.
Yeah, and Todd, just to chime in really quickly, you just made a great point. Most folks maybe on the call, on the webinar, don't know that between last year and this year, CMS made significant changes to those protocols for the first time in, I think, about 4 or 5 years.
You're right.
They actually collapsed tables, got rid of tables. It was a significant change. So
27 some odd tables is ridiculous.
Yeah. It was. We're responsible for maintaining that for all of our clients. So we went through that process. But you know, if you're a smaller operation and you've been doing it accurately a year before this, you could be really looking at a lot of risk if you're trying to maintain that change, because it was a material redesign of those universes.
Yeah, I think the cool thing we're seeing at CMS, and when you and I were in there, they were really trying to make improvements in their overall technology, consolidating information so they could have quicker responses. But I think it was good to see that. You're absolutely right, Ken. It was nice to see some reformatting that makes practical sense. Thank you. Next page. Now, utilization, I know we only got about 10 minutes left into this, Kenan, but we'll try to do a deep dive in utilization management. That way allow some Q&A on this. Next page. So general guidelines and standards. The lead behind on this is really to understanding when you think about utilization programs, the structures, and what are the standards and guidelines. As Kim has mentioned earlier, in your GRC system, having those properly in place and categorized and updated so you have the latest and greatest is critical. When you think about overall utilization management. And then having a good QI process, we find QI or QA is really, really key for this. And you may have a program established, a policy to establish, procedures established, but having people trained on it and actually actively doing it, it's another. And so either you have a system or not, but making sure those things are properly outlined will go a long way as you go through this review internally to make sure your health plan is properly and compliant, but also making sure your members aren't also not being taken care of too. So you're also looking at protecting your member and patient base, right? So the purpose of this is to look at the various components of utilization management, of having appropriate individuals in place, having timeless decisions being done, which feeds back into the overall model to respond back to CMS, but also what are the standards and guidelines that exist, and having something in place to really capture that and monitor that is critical. So next page. So timing of reviews. So you've heard a little about this, what Ken and I were doing before. We were doing a lot of retrospective reviews for the Fed and for the state on program integrity. And what we find is that it's probably not as effective, but it's there. It's a line of defense. It's looking at it, and you should be doing that anyway. But concurrent reviews, that's where you have to have a sophisticated system, kind of like what Ken was mentioning earlier, making sure that workflow and those data elements are actually being properly categorized and properly captured. They can create some capturing there. And then what we talked about being prospective from the top there, thinking through this is like, yes, what can we do beforehand, right? What can we do? And making sure you're looking at trends and analysis, and then keying up potential outlier could exist with this one, an area, an individual, or procedure. Let's make sure we're capturing that properly and make sure we don't have any increase in appeals and grievances as a result from this, or potential callbacks, or potential issues of under and overpayments. And then the ad hoc activities. So thinking about that third line defense, third line defense, making those mock audits, that's where the UMVs come in from our side, from what I do for a lot of my clients. I don't know if you want to touch on this. I know we try to make it as simple as possible, but yeah, being prospective is a part of the process. Being concurrent, yes, real time, retrospective, a lot of stuff we used to do. And then the oversight piece, administrative on the third line defense is third and second line defense is what are part of the reviews. Anything you want to add on this one too, Ken, or no?
I don't think so. I think we're good.
All right, good. Next page. So when you think about what Kim was mentioning earlier, all the tables and consolidations that took place, but these are some metrics to consider as you look at putting a program in place and thinking about medical behavioral services, pharmacy utilization. The big thing with COVID has happened is seeing how this has happened. We're making sure that members are probably being monitored, they're accessing, and that their inpatient days are not overlong. Just admission activities, all just basically capturing the proper data for the member and patient interactions with the provider. So that's really part of it, is making sure that you've got some basic metrics in place. And we've gone this over with the chief medical officers, with health plans, and also on the side of the provider, the downstream side with the providers, making sure they give the right information to us too, because there's data quality issues on both sides. As we find in the health plans, working with provider networks, it's amazing what you find in data management, data quality. Some of it can be wrong, some of it can be fraudulent. So you really have to make sure whatever data you're coming in, it's starting to correlate and make sense, that your population or your member base is properly cared for based on the plan and network contracts. Okay, next page. Well, I think it's our last polling question.
It is a last polling question. Here we go, polling question number 3. What type of reviews can be done for utilization management? Prospective, concurrent, retrospective, administrative, all of the above? It's pretty unanimous here. Yes, it is, everyone.
It's not 36%, what?
No, it's not
Okay.
36%. All the above. Thank you.
Good. Yeah, you're right. I mean, it's however you want to call it. Are you reviewing it or not? That's basically it. And being prospective and making sure you've got good oversight is really key for this. That's where you leverage, companies like ourselves and Ken to help support you in this space. Next page. So essentials for success, right? Monitoring, collaboration, mitigation, and reviewing. And all that doesn't take place in a vacuum. It can't. What we try to stress here, and I do appreciate Ken's time on this, and he's a busy man managing a lot of different clients like myself too. It's amazing what companies do not have in place, specifically on collaboration, just making sure they may have reports, they're working in silos. They're not monitoring it properly. They are monitoring, but they're not collaborating. They're not communicating as well. And so you've got this mismatches, and you've got a risk assessment happens every year between compliance and internal audit, and then okay, you check the box, it's got it done, and present it to the board. And you get a phone call, or you get a letter from your department of managed healthcare or some other legal entity, regulatory entity saying you failed. Like, how do we miss this, right? So it gets back into, when you think about payment integrity and other areas, making sure you've got good programs in place is really key. And it's not just having the great system, not just having great people. It's all part of it. Okay, next page. So I think we talked about this before. Just don't do it alone. You think about your structure, organization, making sure you've got good people in place. I think the stakeholders for a strong program, we've seen this before, and Ken and I have done this as well. Talking with, when we go and talk with health plans or providers, talking how they interact with each other, making sure there is a really good team in place to help support this, and that the compliance and risk programs are there to help support and collaborate, not keep them on the side that only get used once or twice a year, but they're integral and part of that whole area. So compliance and risk is your friend inside, so you can actually quell concerns that are happening. So I think I know that another thing we add any more to this, Ken, that would be
No, I'm good. Thank you, Todd.
yeah, good, very good. And I think believes that's our last slide. So we'll leave it for a few minutes here for any questions.
So if anybody has any questions, I might have to unmute you if raise your hand or put a question in the chat. Okay. Well, thank you, everybody. We will be distributing this slide deck to those of you who attended, so you will look for that email, as well as those of you who have answered the CPE questions. Thank you for doing that, and we'll send that to you. There are Todd and Ken's emails, again, at the back of this presentation deck. And if there's any other information that you need, the partner at rgphealthcare.com, we can answer any questions there that you may have. With that said, Todd and Ken, thank you very much for your time.
Thank you.
Thank you.
I'm going to stop this recording.